Welcome everyone to the 12th webinar of the Comprehensive Neuroanatomy Educational Course organized by the Yemeni Neurosurgical Society in collaboration with the World Federation of Neurosurgery and Young Neurosurgery Forum of World Federation of Neurosurgery, along with Neurosurgical TV, Neurosurgery Couch, and Pakistan Society of Neurosurgeons. Today we have a distinguished speaker, Professor Manas Panigrahi. He is a coordinator of the WFNS committees, and also he is professor and chairman of Neurosurgery Department at Krishna Institute of Medical Science. Also, we have today Dr. Anwar Al-Arhabi, who will be moderator of today's session, and he's assistant professor of neurosurgery at 21st September University. And also we have Professor Abcharian. He is my mentor and my teacher, but unfortunately he couldn't join now. Maybe he will join us later. So, Dr. Anwar, please, you can start.
Yes. Thank you, Dr. Ahmed. We are welcome for Dr. Manas Panigrahi. Today, our lecture about posterior thoracic approach. Welcome, Dr. Manas, one of pioneer of neurosurgery in India. You can start, Dr. Manas.
Thank you, Dr. Anwar. And thank you, Dr. Ahmed, for organizing on behalf of Yemeni Neurosurgical Society and Pakistan Society. And it's a very good initiative for young neurosurgeon because at many places you don't have educational courses going on in many countries, even including some parts in India also. Today I'll can you see my presentation? Hello.
Yes, Professor, we can see it.
Yes, Dr. Manas. Screen all chairs, Dr. Manas. Screen the chair, all chair.
It's perfect now.
Perfect now. Okay.
Yes.
So today I'll be speaking on. I'll not speak very long, but for a short time. I'll be speaking on the posterior approaches for the thoracic spine. I work in Hyderabad, which is in the central part of India. And if you have visited India, like Delhi, Bombay, Calcutta, and Chennai are in four corners, and Hyderabad is in the center. I'll start with the clinical relevance of the topic. I'll set examples of the cases where this anatomy and the procedure will be useful. All of us know that there are 5 common approaches for the done posteriorly for the thoracic spine disease. One is the commonest one, laminectomy, which is done for stenosis or ossified yellow ligament, or tumors or hematoma, or whenever they have a tumor, either intradural or extradural tumor. The second common surgery is a posterior instrumentation, which is done for spinal trauma or deformity or instability. The third common is doing transpedicular decompression for biopsy of the vertebral lesions. And the fourth and fifth common are the costotransversectomy, where tumors which involve the paraspinal area and the body, or a purely anterior body involvement, you need an lateral extracavitary approach. I'll not be speaking on the transthoracotomy or anterior approaches. I'll confine only to the posterior and posterolateral approach. I'll take example of each case and illustrate the principles of the surgical technique. This was a 55-year-old male who presented with weakness of both lower limb, and you can see here the MRI shows a compression at the thoracic level, and it is hypointense, suggestive of a calcification, and the axial cut shows there is ossification of the yellow ligament with severe compression. So these cases just needs a laminectomy. Whereas this patient who came, a 49-year-old man, who came with a road traffic accident with back pain, one can see here the CT scan shows there is a burst fracture of the D12 and the MRI shows a burst fracture with intact PLL, and here you need fixation with indirect decompression. And this is what we have done. We did fixation 2 level above and 2 level below to stabilize the spine. The third indication is transpedicular decompression and fixation. This was a 54-year-old male, came with back pain and paraparesis, with again lesion in the extradural space, posteriorly, laterally, and involving the pedicle, suggestive of metastasis. So we did laminectomy and transpedicular decompression with fixation of the spine. This was again another 21-year-old lady with upper back pain, and there was a lesion again in the extradural space involving the pedicle, destruction of pedicle, and then destruction of the body and destruction of lamina. And we were just operated 3 days ago, and this turned out to be a bony tumor, probably aneurysmal bone cyst. So we did a transpedicular decompression and excision of the lesion, and did an unilateral fixation and drilled the bone till it got a normal cortex and filled the space with normal bone taking out from the lamina. Now all this fixation needs placing screws through the pedicle. What I'll be discussing is how to do thoracic, the techniques of pedicle screw fixation in thoracic spine. All of us routinely do lumbar spine, but thoracic is not very common, and the anatomy in thoracic vertebra is a little different from lumbar. In thoracic, the pedicle is very thin, so one has to have a thorough knowledge, anatomical knowledge of the spine, the orientation to do a pedicle fixation without any complications. Unlike lumbar spine, in thoracic spine, the pedicle is angulated. So one can place the transpedicular fixation either parallel to the pedicle or parallel to the superior epiphyseal plate. Both of them have good biomechanical stability, and I'll be discussing the technique of the entry point and the direction of placing the screws. Now there are 3 ways of placing pedicle screws in thoracic spine. As you can see in the anatomy, one can go straight from the base of the transverse process, the junction of transverse process, and the articular process into the pedicle, or one can go little laterally and make a funnel go angulated, depending on the level of the thoracic spine, because the angle of the pedicle differs in the upper thoracic spine, in the middle thoracic spine, and the lower thoracic spine. And one can go in, out and in technique, when one can go through the transverse process, come out at the level of pedicle, and again enter the body. So there are 3 techniques. So this is called in, out. This is out of the body, and again into the body. So this is in, out, and in technique, and this is directly through the pedicle into the body, like what we do in a lumbar spine. So the first step of doing a pedicle fixation is finding an entry point. The one can use a high-speed drill or a manual drill to have the entry point. I'll explain how to where exactly is the entry point for each vertebra, because the entry point differs in the upper thoracic spine, the middle thoracic spine, and the lower thoracic spine. And the angle also differs in the upper, middle, and the lower thoracic spine. So the first step is making a drill hole through the pedicle into the body. The second is the pedicle finder. Third is tapping the screw. normally you use 4.5 millimeter diameter screws. So one is to use a tap which is 0.5 millimeter smaller, either 3.5 or 4 mm tapping screw, followed by the pedicle screw placement. The thoracic spine can be divided into 3 groups, as I explained: the upper part, the middle part, and the lower part. The middle part from T5 to T8 are the typical vertebra, typical thoracic vertebra. The lower one, D9 to D12, they resemble the lumbar vertebra and they are larger. And the T1 to T4, they are smaller and resemble the cervical vertebra. So the T1 to T4 and D9 to D12 are called atypical thoracic vertebra. I'll be explaining the features of a typical thoracic vertebra and an atypical thoracic vertebra. To operate in thoracic spine, one also has to understand the neurovascular structures related to the thoracic vertebra and ribs. The neurovascular bundle is related to the anterior surface and lower part of the anterior surface of the rib. So whenever one does an extracavitary approach or posterolateral approach, and where the rib has to be removed, one has to separate this neurovascular structure and the pleura, do a subperiosteal resection, preserve these structures, and then take out the rib. And unlike the lumbar and thoracic vertebra, each lumbar and cervical vertebra, the thoracic vertebra has an attachment of the rib. And the typical thoracic vertebra has the 2 ribs attached to each body. You can see here this rib is attached to both upper and lower body. Again, this is attached to the upper and lower body. So you have an additional costal facets in thoracic vertebra, which you do not find in lumbar or thoracic. So wherever the rib is attached, there is a synovial joint on the body, and there is a costal vertebral joint, and the rib also is attached to the tip of the transverse process. There is another synovial cavity here. So one has to understand all this anatomy to whenever one is planning to remove the part of the rib for posterolateral approaches. So once this is a diagrammatic picture to show that once you remove the rib, one can find 2 costal demifacets. So in a thoracic vertebra, unlike lumbar and cervical, you have costal demifacet, one superior, one inferior on each side. So there are 4 demifacets which are not found in other vertebra. Similarly, there is one more costal facet on the transverse process, again, which is attached to the rib. So this ligaments has to be, whenever one planning to remove the rib, one has to detach the ligament so that it can easily come out, and that rib can be used as a graft if you are doing a posterolateral approach. So in summary, a typical vertebra, thoracic vertebra, has a body, has a spine which is very long and inferiorly oblique and inferiorly directed, unlike lumbar where it is transversely oriented and short. The cervical also, they are transversely oriented and short. In thoracic, they are very long and inferiorly directed. They have an additional costal facet on joint on the transverse process. They have a pair of costal demifacet on either side on the body, and there is a peculiarity of the articular process. In lumbar, the articular process are oriented sagittally, whereas in thoracic, they are oriented coronally. So you can see here, they are parallel to the body, unlike lumbar where it is sagittally oriented. So the planning the pedicle screw fixation is very important in if you understand the coronal orientation of the facet joint. So this is how is a typical thoracic vertebra looks like. It has the spinal canal is narrower than the cervical and the lumbar, and it has a rib. It has a costotransverse joint. It has a costal joint or a rib with the body. Radiologically, one can identify all the structures with a CT scan. You can see here in the CT scan the transverse process, the rib, the vertebral body, and the pedicle. So pedicle is very narrow in this case. The descending aorta is situated on the left side, and the vena cava is on the right side. And the same structures can also be identified in the MRI also. It is better to identify all these structures to plan surgery so that surgery becomes easier. If you look at the radiology, there is a defect in the posterior surface of the thoracic spine. They are not fractures, but they are the openings for the basic vertebral veins. They are normal. As you go laterally, one can see the facet joints between the articular process. As I already explained, the articular process are coronally situated, and the foramen is round. Unlike in lumbar, it is like a pear-shaped or inverted pear-shape. In thoracic, it is round. So this is a MRI of the. You can see here in the lumbar spine, the neural foramen is inverted pear-shape, where the upper part has the nerve roots and vessels, whereas in thoracic one, it's not inverted pear, it's a round-shaped structure. As you can see here, this is a thoracic spine foramen. They are round, and in lumbar, it is inverted pear-shape. So if you summarize the uniqueness of thoracic vertebra, the costal facets are there only in the thoracic vertebra. The bodies are heart-shaped. They have a long oblique spinous process. The foramen are circular, unlike lumbar spine, and the joints, the articular facets are coronally oriented, unlike lumbar, which are sagittally oriented. So what is an atypical thoracic vertebra? T1, which shares like a cervical, has a rectangular body and has a well-developed superior vertebral notch. Has a full facet for the first rib. So T1 is an atypical vertebra. T10, T11, 12, and T12, they are more like a lumbar. They have a sagittally oriented articular process. So they are also called as atypical vertebra, thoracic vertebra. So to plan an pedicle screw fixation, one has to thoroughly understand the pedicle anatomy. As I explained, in a lumbar, the pedicles are parallel to the superior epiphyseal plate, but in thoracic, they are not parallel, but they have an angle of 10 to 15 degrees inferiorly. So in a thoracic, when one does pedicle screw fixation, one has to angulate it caudally and medially. In a lumbar, it is usually done transversely. And the angle in a lumbar is 10 to 15 degrees, whereas in a thoracic, it varies from the upper thoracic, middle thoracic, and the lower thoracic. So the angulation in T1 to T2 is around 30 to 40. The angulation in T3 to T11 is 20 to 25, whereas T12 is like 10, which is similar to lumbar. So it's easy to remember that the angulation is more in the upper thoracic and it is less or is like lumbar in the lower thoracic. So so that is how you remember while planning the angulation, or if you do not have a navigation, then one has to anatomically think of the angulation and place the screws. The pedicles are mostly of cancellous bone, but they have a thicker cortical bone medially, and the lateral part actually is not very thick. So this is protective, and hence one should feel that one should not breach the medial cortex to avoid damage to the dura. And one can angle it inferiorly and caudally so that one will not breach the cortex or cause any dural injury. In addition to the angulation of the pedicle width or the diameter of the pedicle also differs in the upper and the middle and the lower. The pedicle width decreases from T1 to T4. The T4 has the narrowest pedicle, and below T4 and again the diameter increases. As the diagram explains, the T4 has the thinnest pedicle. As you go up, the diameter increases. As you go down, the diameter increases. Similarly, not only the pedicle width, but the pedicle height and length also change in the size. But unlike the pedicle width, where the minimum width is T4, but the pedicle height and length increase progressively from the T1 to T12. So the width is thinnest at T4 and it increases on either side, whereas the height and the length, they progressively increase from top to bottom. Now, having understood the diameter of the pedicle and the length of the pedicle, one has to now go to identifying the entry point, how to enter. Normally one takes like lumbar spine, the middle of the transverse process and the middle of the articular process as the entry point. So that is for the typical vertebra, like in the middle part. But as you go up T1 to T3 or you go down, the entry point differs. As you go up to T1 to T3, the entry point goes up, like it's not the mid transverse line, but it's the line going to the upper third of the transverse process and the articular process. So as you go to the upper thoracic spine, the entry point moves superiorly, and similarly as you go down, entry point also moves superiorly. So, and T4 to T6 is the classical one, where the entry point is middle of the articular process and the middle of the transverse process. Whereas in T7 to T9, it is again middle of the articular process, a little lateral, but it moves up towards the upper third. So the easy way to remember is to understand this diagram. As you can see here, that if the middle part is the line joined through the middle of the articular process and through the middle of the transverse process is the entry point for most of the middle part, like T4, T5, T6. Whereas if you go up like T8 and 9, it moves superiorly. And if you go T1, T2, T3, the entry point moves down. So similarly, D8, D9, 10, as you see here, that the entry point comes down. The D12 comes more to the middle, like the lumbar, and as you go to D9, it goes superiorly. So when you're looking at while operating, if this is the articular process is seen, it's easy to take out the inferior part of the lamina and expose the articular process and divide it into medial and lateral half. The lateral half is safe, the medial half is unsafe. Always enter in the lateral half of the articular process. So this is the summary of the entry point of all the thoracic vertebrae. You can see that T1, T2, T3 is the middle part of the transverse process, whereas T5 and it is the proximal third towards the upper part till T9, and again when you come down to D11, 12, again it comes to midpoint. So the easy way to remember is the middle part is in the upper third of the transverse process, whereas the upper spine and the lower spine are in the middle of the transverse process for entering the pedicle. Once you've done fixation, decompression can be done two ways. One is a direct decompression and one is an indirect decompression in traumatic spine. In a direct decompression, one does a simple laminectomy and remove the compressing bony fragments. In an indirect, it is ligament taxis if the ligaments are, if the posterior spinal ligament is intact. I'll explain diagrammatically what we mean by indirect decompression. So direct decompression is done whenever there is a neurological deficit, and whenever, as you can see here, that the lamina is fractured, and sometimes the root and the dura can be entrapped. In these cases, the lamina is removed and the dura has to be repaired. And whenever the fragment of the bone in a burst fracture has 180 degrees rotation, as you can see here, that the bone is reversed 180 degrees. In these cases, are there small pieces of bone which, and posterior ligament is not intact, one has to do a direct decompression of this kind of fracture. Whereas if there is no rotation of the fragment, one can do an indirect transpedicular decompression or indirect decompression. In indirect decompression, one does the laminectomy, then one drills off the pedicle, and then uses one can use an impactor to impact the fragments into the body. One can create a drill and create a space in the body, and then use the impactor to decompress the ventral part of dura. But if you have the posterior ligament is intact, then one can do indirect decompression. It's called ligamentotaxis, where after putting the pedicle screws, one can after putting the pedicle screw, one can distract both the pedicles. So the as you can see here, that the bulge has come forward. So if you correct the kyphosis, the ligament, posterior ligament pushes the fragment. It's called ligamentotaxis. So the prerequisite for that is that ligament should be intact. Then one can do a indirect decompression. Whereas indirect decompression should not be done. It's contraindicated if there is a reversal of the reversal cortical sign. If the retropulse fragment has rotated more than 180 degrees, you can see here the black line and the red line. The red is the cancerous bone. If it's rotated more than 180 degree, one should not attempt an indirect decompression. One should do a direct decompression. So this is what is indirect decompression. Once you put the pedicle screw, one can yeah. Can you hear me?
Yes, Professor, we can see you and hear you.
Yeah. Okay, that's fine.
We hear you, Doctor. Yes.
Yes. So this is how you do a ligament taxis, where if you once you distract, the posterior alternate ligament will do a decompression called indirect decompression. So I have explained you the the three common procedures: laminectomy, posterior instrumentation, how to put a pedicle screw, and how to do a transpedicular direct and indirect decompression. The two other technique which I'll be explaining is costotransversectomy and lateral extracavitary approach. It is done whenever the lesion involves, in addition to the pedicle, if it involves the body. If involves anterior column, one needs a lateral extracavitary approach. If it involves only half of the anterior body, one can do with a costotransversectomy. So this is a diagrammatic presentation of the extent of exposure of the body. If one does only laminectomy, one can have an exposure to the pedicle to a limited amount. One removes the pedicle, one can have an exposure to a larger extent, and one removes the rib, and one can go to the opposite side also to decompress the whole body and place a graft. So basically, posteriorly, there are 5 approaches: laminectomy, transfacetal, transpedicular, costotransversectomy, transthoracic. I'll not be talking. So the angle or the angle of vision differs depending on what approach one does. So lateral extracavitary approach, when you remove the rib, one can reach till the anterior surface of the vertebral body. In a posterolateral costotransversectomy, one does the similar to laminectomy. Some people use a linear incision, but we use a curvilinear incision and reflect the flap, and then reflect the muscle transversely and take out 5 centimeters of the rib. Whereas in a lateral extracavitary, you remove 9 centimeters of the rib, and then expose the pleura to have an access to the body. So the difference between a posterolateral approach and a lateral extracavitary is the extent of rib removal as well as how the muscle is resected. In a posterolateral costotransversectomy, one reflects the muscle from midline laterally, or one can do a transverse cut through the erector spinae along the rib, whereas in lateral extracavitary, one works lateral to the erector spinae muscles. So this is a case of a 70-year-old lady with severe back pain with no deficit. She came with destruction of the 11 vertebra, and you can see here. And so we did costotransversectomy for this lady. As I explained, we use a curvilinear incision instead of midline incision, reflect the flap, and then dissect the muscle from midline, make a transverse incision along the rib, and use the rib, excise the rib, as I explained, and use that rib as a graft after the diseased bone is removed, and then do fixation with 2 level above and 2 level below for stabilization. In a lateral extracavitary approach, as I explained, the rib, you remove 9 centimeters of the rib and then work on either side of the erector spinae. The erector spinae, you work lateral to erector spinae, lift the erector spinae superiorly, or one can cut it transversely along the rib also and then re-anastomose also. So when you remove 9 centimeters of the rib and then do extrapleural dissection, one can take out the whole body. If the whole body is diseased, normally it is done on the left side as the aorta is more thick, so the chances of vascular injury is less. On the right side, you have the veins, and the chances of venous injury is higher. So you try to avoid on the right side. Normally, you do on the left side. So usually you expose 3 ribs so that one has a good exposure. But you expose 3 ribs, but then take out 1 rib for an access for the graft. And if fixation is required, one can remove all the 3 ribs and then do a lateral fixation also through the extrapleural approach. So this was again another patient, 50-year-old male with back pain, and this is what the scan showed. This was a tumor in the mid-thoracic level, a large dumbbell tumor, which is a large thoracic component, and going into a spinal canal and destroying the half of body. So we did a lateral extracavitary approach. We removed the rib, did extrapleural removal of the thoracic part, and then removal of the intraspinal part, and then we'll remove the part in the body of the thoracic vertebral body also, and then did fixation. This is the post-op X-ray showing after fixation, after removal of the tumor. So as I explained, in a posterolateral costotransectomy, only 5 centimeter rib is removed, whereas in lateral extracavitary approach, 9 centimeter of rib is removed. The neurovascular bundles are separated from the rib, and the pleura is preserved to avoid pneumothorax. And extrapleural, one can do tumor excision, as I just showed the scan that we did extrapleurally remove the tumor. So this is the extent of exposure with both the approach, that the lateral extracavitary obviously gives a better exposure than the posterolateral costotransectomy. So here one has to be clear on the anatomy of the neurovascular bundle in relation to the rib and the intercostal muscles and the pleura. As I explained, when one has to also be careful in deciding which side one has to do posterolateral approach. Left side is preferred as the aorta is there, but if the paraspinal abscess is more on right side, one can do on the right. But if the case what I showed, there is not much of paraspinal abscess, more of destruction of the body, so we did from the left side. In conclusion, thoracic vertebra is unique in having narrow pedicles, and it differs the upper part, the middle part, and the lower part. The pedicle length, the pedicle height, the pedicle angulation differs. One has to understand all this in placing the pedicle screws without any complication. One has to also understand the pleura and the neurovascular anatomy properly to do the posterolateral approaches. Before I conclude, I'd like to invite all of you for the annual conference of the Neurotrauma Society of India. We are hosting at Hyderabad in August 7th to 9th. I welcome you all. If any of you are interested, please let me know. We'll organize everything for you. Thank you for your attention. If anybody has any question, I am free to answer.
Thank you, Dr. Manas, for your nice presentation. And we ask all our colleagues, if there is any question, please send it for chat, and we will give it for Dr. Manas. Are there any questions?
Thank you, Professor. Thank you, Professor, for this very nice presentation. It was comprehensive, and it explained almost all the approaches of the posterior thoracic spine. I have a question, if possible. I see in few cases that you do unilateral fixation. So you do it only in cases of tumors, or you can also make in other cases?
No, because that case was a tumor and it was involving that facet on one side. The other side was intact. So we did only unilateral. But in trauma, we normally do bilateral. Or when we do a total vertebrectomy, the whole body is diseased, then again we do bilateral.
And in some cases, Doctor, okay. Please continue.
Yeah, I mean, if it's a benign disease, that was an aneurysmal bone cyst. So if it's a giant cell tumor, can do with unilateral, or a neurofibroma, we do unilateral. But if it's a metastasis, where it's a malignant disease, or a trauma or instability, we do bilateral.
Thank you, Professor. And
Thank you. Thank you, Dr. Manas.
Thank you.
if I can ask you about your opinion, in some cases, when we have a trauma in trauma cases, when we have a fracture of the body, and the pedicle are somewhat intact. What do you think about one level up and one level down with including of the fracture site? Do you usually do that, or you only do 2 level up and 2 level down?
No, if it's thoracic, pure thoracic, like mid thoracic, I can do 1 level above and 1 level below. But if it involves the junction, like if it involves the D12, then because it's a junction between the mobile and the fixed segment, normally we do 2 level above and below. Or if it is cervicothoracic junction, again upper, then again we do 2 level above and below. But if the two bodies are involved in the disease, like it's a tumor or a trauma, then again we do 2 level above and below. But if it's a mid-thoracic single level disease, 1 level above and 1 level below is enough.
And in junctional region, like T12, if I do
Junctional
fixation, if I do
we do
T11 and T12 and L1, is it possible? If I include the fracture site?
Yeah, it is possible, but the recommendation for junctional level is always 2 level above and below.
Thank you. Let's see if you have any question in the chat. We have, okay. Dr. Muhammad Al-Haq, he has a question. Do you prefer short segment usually in dorsal spine? I think you already answered that.
Yes.
Okay. As you said, in pure thoracic, you do 1 level above and 1 level below, and in junctional, you do 2 level and 2 level.
Yeah, only if the single body is involved, 1 level above below. But if thoracic, mid thoracic, 2 bodies are involved, then I again do 2 level above and below.
Okay.
Depends on the extent of the involvement. Yeah.
In thoracic spine, Dr. Fixation during surgery, lateral view of the CR usually will not be sufficient to visualize the pedicle. How do you solve this problem?
In thoracic, usually I means as I explained, anatomically we place the percutaneous, the needles, or make drill through the drill and then place either PAX needle or place an LP needle and do an AP X-ray and confirm that you are going through the pedicle, and then do with the lateral. We use both AP and lateral when you're using only C-arm, but we also have O-arm. We use the O-arm with navigation in pedicle screw. But when you're using only C-arm, usually with entry point we decide with the AP, and then the depth we decide with the lateral.
Thank you very much, Professor. Dr. Anwar, do you have any remarks?
No, thank you. Our colleague, are there any questions? Our colleague, are there any
anyone
questions?
have any question, please, you can ask, raise hand and ask directly, or you can type in the chat for Professor to answer.
No.
I don't see any question.
Yes.
So, Dr. Anwar, would you like to conclude the petition?
Yes, thank you very much, Dr. Manas, for your nice participation and for a nice presentation today. And thank you for for all colleagues that enjoying by this nice presentation.
Thank you for inviting.
Yeah. Thank you, Professor. It was a great honor for us to have you with us, and we are pleased and honored by your participation. So thank you, everyone, and by this we can conclude our 12th webinar, and see you all, inshallah, next week.
Inshallah.
Thank you, everyone. Thank you, Professor.
Bye. Bye.
Bye-bye.